how you're doing it.
I'm a crazy person. Okay.
America's medical system needs healing. Free to Care has real solutions. Our mission is to magnify the voices of the patient and physician. We want to take medicine back to its original purpose. Join host Dr. Nikki Johnson for Free to Care, the podcast, for conversations on lowering prices, making prices transparent, personalizing medical care, taking bureaucrats out of the system to bring you more choices for your healthcare dollar. We know that healthcare is personal, not partisan. Join us live Fridays at 8 p.m. Eastern for Free to Care, the podcast.
Okie dokie. All right.
I love the intro. Love
awesome. I just fixed that. That's the new intro. So you get to be here when we debut the very new intro. Yes, I did.
Wow.
And I was practicing my breathing and everything going through. So it's just so interesting.
I'm totally impressed. I really
All right. All right. So hi, everybody. Let's see how many people have tuned in so far. We got 5 people on. Hi, everybody. Good.
Hey.
So welcome to this 4th episode of Free to Care, the podcast. I am your host, Dr. Nikki Johnson, and I have guest Dr. Kimberly Legg-Corba with me tonight. We'll introduce her in a sec, but tonight is the moment that a lot of you have been waiting for. A lot of people have been asking me in the Twitterverse and on another podcast that I did with the Conscious Conservative Media Network, Ms. Pinky. We talked about what is it that we can do to actually lower the cost of healthcare. Well, tonight's episode, we're going to talk about how you've really been told lies about the whole thing. Healthcare itself is unaffordable and expensive. It is a huge market. It's a huge racket. It's a huge production. But the medical care, the actual care you get from seeing a doctor, and getting your supplies, getting your pharmaceuticals, all of that, everything that goes into that is affordable. So Dr. Corba here is a family medicine physician who owns and runs a direct primary care practice. Welcome to the show tonight, Dr. Corba.
Thank you for having me. Thank you.
Awesome. Thank you so much. I've been so excited about this. There are so many people who actually do not know what direct primary care is. But first, just, introduce yourself, tell everybody, who you are, what you do for a living, maybe a little bit about your practice, and then how you got affiliated with Free to Care.
Okay. Sounds
and
good.
A little bit about DPC Action too. Just sort of give your a couple liner about who you are.
Okay. Thank you for the wonderful introduction, and thanks for giving me the opportunity to be here tonight. Again, my name's Dr. Kimberly Legg-Corba. I live in Allentown, Pennsylvania, and I've been in practice for 24 years. I'm board certified, family medicine, and I have a very small independent practice here in Allentown. I actually opened it in 2003. And literally hung a shingle and just started with 0 patients and slowly built up the practice. I took insurance back then, and I took insurance for 13 years until 2015, when I saw an amazing talk given by Dr. Josh Umber, who is one of the gurus and original pioneers in direct primary care and the whole movement. Saw a talk given by him at AFP that inspired me to decide to transition my practice from an insurance-based practice to direct primary care. So that transition took place through the last quarter of 2015, and we opened the doors as a direct primary care practice in January of 2016. So I'm in my 6th year right now of DPC, and I'm basically a community doctor. I've always been kind of the old-time family doctor that I grew up with, and a lot of us grew up with. And basically all I did was transition the way people were paying for their primary care by getting rid of the insurance. If you're wondering, or if anybody's wondering why I did that, I had a full, very successful practice. Pretty much put a bomb in the middle of it when I decided to transition, and it was a risk because I was the first one in this area to do it. There were many other GPC practices across the country and in this state, but I was the first one in this area, which is we have a population here in the Lehigh Valley of about 800,000, and it's growing rapidly as people move out of New York and New Jersey for various reasons. And we have two very large hospital systems, very heavily insurance dominated. So it was definitely a risk, but I felt like it was something I needed to do for my patients and for myself, so I could keep providing the care I wanted to and practice medicine the way I wanted to for my patients. So
Kim, can you pause here and just go backtrack a little bit and tell people what practicing was like before you switched to DPC, and then what enticed you about DPC that
Sure.
prompted you to make this switch?
So when I first opened the practice, I knew there was a few things I could control as far as my overhead. I wanted to keep my overhead low in 2003 and moving forward. And I knew there were certain overhead costs I could control and certain ones I couldn't. And I did a really good job of keeping my overhead low enough that I could spend longer time with my patients in the beginning, in 2003 on. It really started getting bad in 2010. That's when I started feeling the crunch that I couldn't spend the time with my patients, and so much administrative stuff, with the advent of the EHR. I had paper charts. A lot of doctors had paper charts back then. With the advent of the EHR and all of the regulatory things that were coming down the pike and all the data collection that started from the insurance companies, it was really just eroding. It was stressing my staff out. I found that they couldn't spend as much time on the things they were supposed to because of all the administrative burdens that were happening. I wasn't being able to spend as much time with my patients. We were, I was clicking boxes and reporting things that I didn't need to report because they were getting done anyway. Nobody needed to babysit me, and the insurance companies certainly didn't. But my reimbursement was starting to depend on me following all of these things that the insurance companies were mandating, which was useless activity. And it was all to control costs and to make sure their profit margins stayed high. I mean,
so let's pause there. Just let everybody know that too. So when you go see a doctor and they're clicking away on the computer as they are talking to you, or after they get done talking with you, they have to check certain boxes in order for your insurance company to, and that includes Medicare especially, and Medicaid. You have to check these boxes to make sure these things are documented, that you actually did. You did. Your nurses know you did. Your patient know you did. But they need to know that it was done on this day in order for them to actually pay the clinic, the hospital, or the doctor for the service that you got that day. So just so you know, that's what that means. Okay. And it costs money to do that. It costs money to have somebody.
Being in a small office, I think it was really magnified in my office because I had limited staff, and that was part of me controlling the overhead so I could bring the best service I could to my patients and spend the time with them. And my staff was totally stressed out. I was stressed out. And it was almost insulting because I know how to manage a blood pressure and a blood sugar. I don't need to report that my diabetics' hemoglobin A1C is below 8 or 7.5. And if it's not, I'm working on it with the patient. Why? And so, I still have the reports in my office. I've kept them. They're almost 10 years old now. And, they would put you in a tier of reimbursement based on, and if I had a whole population of hard to control or non-compliant diabetics, my ratings would go down. But I might be working on getting them to be compliant. But in the meantime, my reimbursement went down. Then insurance companies wanted to hear nothing about, the patient's really difficult. I'm making headway, but you're going to cut my reimbursement because I'm actually taking on a difficult patient who's struggling, and I'm trying to help. So it really felt like it's kind of like an insult, like we were being babysat with the stupid data stuff.
So take into account all of the factors that you can't control. Say
Right.
your patient is chronically ill, or they're the sole caregiver for an elderly parent or a chronically ill child, or they can't afford their insulin, which we'll talk about.
Well, right.
All of those things.
And you bring up a really good point, because if a patient isn't, well, and this pandemic's a perfect example. Everybody's blood sugars and blood pressures went off the charts. Everybody gained, a lot of people gained weight. Some people lost weight. But I mean, imagine the data during this pandemic, because
Oh, wow.
I've been chasing everybody's blood pressure and cholesterols and blood sugars all year. And I understand, because there were extenuating circumstances. This pandemic has affected people in countless ways. But if you have to submit that data, if I would have to submit it to insurance, my reimbursement would have dropped this year. Yep. You can't control what happened outside with the pandemic and how emotionally or physically it had affected people. So ridiculous. I got fed up with it. And even though I was rating really high with the insurance companies and with our local hospital system, who was also collecting data, I just wasn't how I was taught to practice. And it wasn't what my original, I went back to my original mission statement in 2003, and I had veered way off. Okay. And I thought, I got to reel this in, or, I have to make a decision. So that's when I decided direct primary care was what I wanted to try. And I could have sold my practice for a lot of money to the hospital. I didn't want to do that. I didn't want to keep being on the hamster wheel. So anyway, it was a risk, and it's obviously I'm here 6 years later, so it's working. Yeah, and my patients are happy. And gosh, I had 3 patients today. I spent an hour with each one of them, and it wasn't just it was for physicals, but we talked about all of their chronic issues, a few acute issues mixed in. When I took insurance, you couldn't do that. You couldn't do a physical and an acute visit. You'd have to tell them to come back, or if they had a new chronic issue they wanted to talk, the billing wouldn't allow you to do that. So I also got tired of telling people, I'm sorry, I can only talk about 2 or 3 things today. You're going to have to book another appointment to come back, take more time off from work, sit in my waiting room longer, pay another copay. That's ridiculous.
Yep.
So
yes. Yeah, that is the key. A lot of people don't understand that, and they will blame the doctor that, oh, they didn't want to talk about my this and this this thing that was really bothering me, even though I was there for a physical. Well, that's why. Or you call in and the doctor tells you they need you to come in. Well, it's they have to document these certain things in order for you to get. Your insurance will pay for this. Right. Otherwise, you're getting a big fat bill too. You don't think about that. But on the other end, got to pay the bills to keep the doors open. Got to pay the people who work there too.
And then, suppose they come in with 5 problems and you can only talk about 2 or 3. How do you know which one? It could be chest pain, shortness of breath, numbness in the feet, urinary tract infection, sore throat. You have to decide which ones are most important and pray that the other ones aren't leading to something else before they come back and see you again. I mean, it's just ridiculous. So for the amount of money people are paying, including my family, for health insurance, people wouldn't pay this much for their car insurance or their homeowners if they were getting this kind of service, right?
Yep. And you would have the option to switch. Right. If you weren't happy or satisfied with that insurance because they weren't giving you what you thought you were paying for, you just go and switch. You get online and compare rates, and you pick another one and take your money and go elsewhere.
And transparency. Yes. Mm-hmm. So that's the other thing. Direct primary care. I love we are 100% transparent about our pricing. I dispense medications, generic medications out of my office, like my family doctor did when I was little. We would go in, have our sore throat, walk out with our little white envelope with our amoxicillin in it. And, so I can dispense any generics through a wholesaler, and we transparently market up a small percentage to cover bottles and labels because we dispense in the office. And even if patients have low copays most of my patients have insurance, some don't. But even if they have a low copay for their medications, just they'll just take it from the office because it's just so convenient. And when they see the price difference and I can pull up some of my prices. I mean, 90 days of generic amlodipine is like less than $2.
All right. So you guys, that's a blood pressure medication.
Right.
Right there.
Sorry. Yeah.
Yeah.
Mm-hmm.
And it's a common one used in Black people.
Right.
So for a lot of my
right.
peeps watching this,
yeah,
that's how much it costs, but that's not how much you're paying at the pharmacy.
Nope. And metformin
with your insurance,
really,
that's what I'm saying. Okay.
Right, with your insurance. Yeah. And so where's the markup happening and who's keeping that money for what you're paying for your insurance? It's like the biggest heist in history. I really believe that.
Yeah. All right. So, okay. There's so much to go over, and an hour is like a cheating amount of time. But what I really want to get is, I know how you got in free to care. Everybody else, can get that. The free to care really stands for helping us get back to that original. I'm a patient. I want to come see my doctor. I actually have a problem, or I want to stay healthy. And I want this relationship between me and my doctor to be this way. I want to choose my doctor myself. I want to be able to shop around if I don't make a good connection. I want it to be something that I can pay for, and I want to be able to get my medications if I need them, or services at lower cost. So we know that, and this is what free to care wants. And direct primary care is one of those huge components of free to care that is we're trying to let everybody know is the way to kind of cut those costs. It's not the only way, but it is a big step to get back to doctor and patient.
And we're not the solution. We're a solution that's working despite all of the barriers that are in our way, and we have figured out ways to overcome those barriers. And I just look at direct primary care as an example that something can grow out of that. Or you can use us as an example to make changes in regulations and law and legislation. We're not going to take over the world. It's not for everybody, but I look at the words free to care, and selfishly, I think I'm free to care for my patients and care about them the way I want to. And on the patient side, because this is all for the patients, it doesn't matter what I think if the patients aren't happy and aren't getting the care that they need. It's all about the patients. So if a patient looks at free to care, I look at it as they have the freedom to decide what care they get.
Correct. More choices.
Right.
No, okay, so let's go now while we're on the patient. So the viewers who are watching are predominantly not physicians. They are people who want to know how we can lower this, how I can pay less going to the doctor, how I can get the services that I need. And what can you tell them about, like, just you can go with your specific practice or just kind of in general about direct primary care, that how it would be like, what does it work like? How is there a monthly fee? Do I pay like a membership fee? Is it like, going to the gym, or is it Verizon? What is it like?
So we like to say you can binge on your healthcare, and it's like the Netflix model or Costco membership. Basically you pay, and most doctors charge a monthly fee, a medical service fee. Some will do it quarterly, some do it annually. And I'll explain the difference between us and concierge care in a second.
Yes.
There is a difference. Yeah. We consider ourselves more of concierge care for the masses but we don't take insurance. And concierge takes insurance. And again, I'll explain that in a second. But most of us do a monthly membership fee that's less than your cell phone bill. It can range, from anywhere, generally like $20 a month for kids up to $100 a month for some of our seniors. Mostly it's age-based. And basically you never bring any money to the office. There's no copays. You get same day, next day appointments for acute visits. We do a lot of telemedicine. So on a side note, when COVID happened, our ability to shift to telemedicine was seamless. We didn't have to worry about the reimbursement or what CMS was saying for Medicare and Medicare reimbursement, which hung up the doctors. and hung up the patients too during the first 4 weeks of COVID. We were already, we just switched right to telemedicine. So I could see a patient every day in my office and there's no extra charge. I can see them once every 6 months. I could see them once a month. There's no limit on the visits. And most of our visits, most of us book half-hour visits because we have a smaller patient panel. So we can give that time to our patients. I do 1 hour physicals and 1 hour pap smears. If a patient has 5 issues they want to discuss, my front desk knows to book me an hour. Nobody's ever waiting in the waiting room. And the telemedicine is free too. There's no charge I just was actually texting a patient before we started this podcast. They're away on vacation and their daughter got hives. So I just sent in some medication to the pharmacy for her. They're away and they didn't want to go to urgent care. So I just saved them $300 from going to urgent care.
But that's incredible. That's incredible. That's what most people would do. Or, if you live in a big city, there's a CVS
minute clinic
on every corner.
That is a minute.
Yeah. And you just go in and you hope you get somebody who knows what the heck they're doing.
That's right,
with your kid. But to have their own doctor who knows them very well and your family be able to do that while you're on vacation is it's almost unheard of nowadays for a lot of Americans.
Right. A lot of them just, the knee jerk is just go to the urgent care, and the urgent cares are not cheap. And
that is true.
I know what my copays are for our policy for urgent care, and our ER copays are even higher. And we have my family has a $5,000 deductible. So a lot of families in DPC have high deductibles and they choose not to use their deductibles for affordable primary care services and just save, the deductible, God forbid, there was a catastrophic issue. But anyway, back to the charge. So that's what that monthly member, it's like access, 24/7. People, we don't get paged 24/7. People are, know to call for an emergency after hours and, for routine stuff during the day. And if somebody texts me at night for a refill, I just take care of it the next day. And then on top of it, we have the dispensary, which is really inexpensive, generics and over-the-counter medications. I use the 3rd largest wholesaler in the country that also supplies CVS and all the major pharmacy chains. So I can get even the same over-the-counter medications that you see when you walk into Rite Aid at wholesale. And then I also draw labs at client bill prices. So like a CBC is $5. Which is cheaper.
Yeah, that's your blood count, guys. So when you're going and you're just getting a basic blood count, say you feel like you're anemic, or it's just that kind of routine, just checking on your annual check, your kid's annual check. That's what that is. $5.
$5. We charge a $5 draw fee, but vitamin D is a hot thing. The insurances don't like to pay for vitamin D, even though, now with COVID, we know vitamin D is so important. My husband had a vitamin D drawn a few years ago and we got billed like $200 for it because we hadn't met our deductible. I can draw a vitamin D for $17 in my office.
Wow.
So that's on the higher end, but like hemoglobin A1Cs, they're about $5.96, and that's for diabetics who check their blood sugar every 3 months. The other thing we do is we've negotiated like client bill wholesale deeply discounted imaging prices at our local imaging facility. It's an independent freestanding, and I can get a CAT scan for $300, an MRI for $450, a chest X-ray for $40. An ultrasound of the thyroid for $175. And luckily, one of our local hospital systems also is doing a great job. And we'll talk about the transparent pricing that the hospitals are supposed to be posting, that I know Free to Care is all over this right now.
Yeah.
We have one hospital system that they finally got caught up, but their prices are a lot higher than the other. And so I will comparison shop with my patients while they're in the room on the computer if they want to cash pay, even when they have insurance. It's taken, one hospital was ahead of the ball, ahead of the game, and had their transparent pricing posted before it was mandated. The other one has been a little bit slow, has caught up, and their prices are not as good as. It's interesting because they're right next to each other, and you think they would compete with their prices, but so
that's interesting too. We've actually had a bill in Ohio for a few years now, before President Trump had a price transparency rule through HHS. Ohio lawmakers actually created a law that demanded transparency. And so we have it actually on the books, but the Ohio Hospital Association and the Ohio State Medical Association are fighting against the bill. Now, the Medical Association does have some legitimate reasons. There are some stipulations in the bill that are going to make things a little bit tougher for independent practices to actually do this in a way, that doesn't overburden them. So that's what they're specifically fighting for. But the hospital systems themselves, they have all of the personnel that they need to be able to do this. There's absolutely no way it's overburdensome for huge hospital systems that are buying up community hospitals and independent practice one after another. They can't, print a list of how much things cost, and we know why they're doing it.
their billing structure is so convoluted and so complicated. You can't tell me that they can't spend some time and resources on posting transparent prices. They put a lot of work into making it complicated in other ways.
Yes.
We all know that they can do this. And
and so the simple and the thing that makes us so terribly frustrating for everybody. For one, the things that bring in the biggest revenue to hospitals or health systems are procedures. Mm-hmm. So anything that you go and get your colonoscopy, you go and have a surgical procedure, you get sedated, you go and have an MRI or any kind of imaging, those things, they can quote you a price on that pretty easily. I mean, and they would know what it is based on what your insurance has negotiated, with the hospital. They can tell you that ahead of time. And so a lot of patients don't know that they can call and actually ask for that ahead of time, or choose to go, elsewhere to have it done. But are you going to get the runaround right now? Absolutely. You're going to get people I don't really know that. You have to call this person, and you will end up calling 1,000 times before you actually get an answer. And so these are the things, though, that we know how much they cost, because we know how much the hospital, they know how much they spend on the materials, the equipment. They know how much they pay their staff. They know how much they pay the surgeon. And they know the average times they spend in the OR for a particular procedure. So they can give you this information. This is information that the hospital is collecting already anyway.
That's right.
So it isn't, this is not as difficult as they're making it.
And if they can come up with a cash price, they obviously know what their cost is to do the procedure.
Absolutely.
And they're still making a profit off the cash price.
Yes.
So I need a colonoscopy soon, and I'm due. And we haven't even touched our deductible this year. It's $5,000. And I was told how much. It's like $2,500 if we do it through the insurance is going to go towards our deductible. Well, I can pay $1,100 cash and go, and so I'm going to pay the $1,100. Why would I do what? Just to try and hit my deductible? I'd rather roll the dice, and if God forbid we have a catastrophic issue, then we hit the deductible. But I mean, chances are we're not going to hit it. So why would I spend $2,500 versus $1,100? And they're still making a profit off the $1,100. So
yes, they are. Yes.
It just doesn't make sense. It's like we're paying our premium and I'm self-disclosing. This is my family story, but it's a lot of family stories. It's very similar. And, $1,900 a month and I can't even use the insurance. So
because the deductible is so high. So I have a question from one of the audience members. This is Mother Mother knows
Mother knows
best.
best. Yay!
She's one of my Twitter followers, a Texan. I love her dearly.
Uh-huh.
Hi, Dr. Nikki. We need a national directory of these doctors. This is great
Oh,
info. So where can people go who want to find a direct primary care doctor?
you can go to one of the places that has a lot of the doctor's practices is called a website called DPC Mapper. It's the letters D, P, C, and then mapper.com. And then it pulls up a map of the United States, and you can actually, zoom in on your state, and it has little dots, and you can click on the practices in the area. Now,
DPCmapper.com, like all one word.
Yep, dpcmapper.com. Now, I do want to, there are different kinds of DPC practices. There are some corporate versions that are not small independents. I represent the small independent practices because we're small businesses. We're the little guys out there rolling up our sleeves and working hard every day for our patients. And not that the big corporate ones are too, but they tend to work a lot with larger employer groups that are trying to save money. So the feel's a little different. It's a little different in the larger corporate DPC practices, but you can still get great care there too. There's about 2,000 independent small DPC practices. We're super invested in what we do because there are businesses, and if we're not making our patients happy and doing what we're supposed to, then we won't have it. We won't have an office. So,
right. But you want to have food to eat. You have to feed your
That's
family
right.
too, right? So that's
Well,
important.
it's rewarding. Right? Yes. My kids can't eat Lipton cup of soup all the time.
Right. We all went into this to care for our patients, and we want them to be well. We want to keep them out of the hospital, right? And then if they do have to go in the hospital, we want to make sure they, get better and recover, and then we prevent them from going back in the hospital. That's what we want. That's why we all became doctors. Or
right.
On my end of things, if they're sick, I want to get them better. So, the other piece, so there's different types of practices, like you said. There's the independent direct primary care doctors, but there are some independent direct primary care practices that don't take insurance. Some do take insurance, like a hybrid. Those are all different, right? So will they be able to find this information out using the mapper? You just kind of click on it and find out information about that practice.
Right. Okay. The dots are color coded based on whether it's a pure DPC means no insurance and small independent practice.
Okay.
And then I think the red ones are hybrid, and then I think the yellow ones are corporate. So you'll be able, and when it takes them to their website, so they'll be able to tell. And you can certainly direct any questions to me. If anybody has any questions, I can help out. Because we all have a large network. We all talk to each other, all the DPC doctors. And in fact, sometimes and this was something that crossed my mind when this mom texted me before this podcast started with her daughter with the hives. I have on occasion called a DPC doctor in the state where a patient may be on business or on vacation and say, hey, can you take a look at my patient? And we do that for each other. So.
Oh, that is so cool. I love that. I mean, just that collaborative nature of being a physician is it's one of my favorite things too, because we learn from each other too, and just patients just get better care that way.
Great.
So kind of are you able to give like a sort of an average membership fee or a monthly rate for people? Like or even a range would help, because a lot of people ask me that question.
So it depends on the area. Overhead is different in urban and suburban areas versus rural areas. So you're going to see price variations, but they said the average adult price is between $60 and $70 a month. I'd say the average kid price, and you will discount if the adults are members, the kids get discounted in a lot of the practices. Okay. I've seen those ranges between $10 and $25 a month.
Okay, so these are like per person.
Per person.
Okay, got it.
And I mean that just saving, I just the time, and what I hear about what the parents like about having the kids is it's the same doctor that they're talking to all the time. and they're not getting whoever is available for an appointment. And that doctor know my kids, and I'm getting you on the phone, and I know you can get them in the same day or the next day. I mean, how many times do family doctor, we get these calls all the time. My kid needs a physical in the next week,
Yep. They're starting sports, or they're doing summer camp, and they need this particular thing documented, or school starting, whatever.
Right.
Yep.
I forget, my kids go to a huge and I love my pediatrician, but his practice is huge. We can never get in there in time. So like, these are the little things that 10 or $25 a month, the parents are like, that's totally worth it, So
what, you don't doctor on your own kids? Come on.
No, I will plead the Fifth Amendment on that one.
I don't do it. I don't. I'm not my kid's pediatrician. I refuse to do that. I'll look at things, look in the ears, listen to hearts, that kind of thing. And, if I'm really concerned about something, but no, I don't manage them. I
strep throats. I will admit that. Yeah. Instead of getting
or an otitis, especially if it's in the middle of the night. I'll take them in. I'll take them into the hospital, because I don't keep an otoscope at home. I try to have very little at home for me.
Then you're not tempted.
Yes, I used to, and I just stopped. Like that. That's not. It's just my emotional level is just too high, and I don't make the most sound decisions.
You can't remain objective. It's hard with your own family, no doubt.
Right.
Yeah.
Right. Okay. So one other question, a lot of people. So you're a primary care doctor. So you're a family physician. There's some internal medicine doctors who do this as well. Pediatrics who do this type of a practice. What about the specialists? What about the surgeon? So if somebody wants a practice like this, are those available?
Keith Smith, a surgery center in Oklahoma, is probably, without, he's not direct primary care, but he's as close to our philosophy as they get.
Yes.
And he's
one I'm going to be, I'm putting a request out, Keith, Dr. Smith. I'm going to need you to come on and talk to me and talk to everybody about Surgery Center of Oklahoma. So
his story is amazing.
Yes.
And he met some obstacles in the beginning, but it was all about transparent pricing and selling the medical services of the surgeons and the anesthesiologist in his surgery center for transparent pricing. And so, the common core values are the same, even though he's not a direct primary care office, he's providing direct care at transparent pricing for the surgery aspect of it. So there are surgery centers popping up around, with transparent pricing, or established ones are starting to post transparent cash prices. But as far as like doctors' offices that do this, there are specialists doing it, and rheumatology, Ellen McKnight in Florida. There's a few others. Psychiatry, I think we're starting to see. That could be huge. Can you imagine if you have a chronic psychological issue or psychiatric issue, or your child does, having access for a monthly fee, it's hard to get in to see a psychiatrist.
Absolutely, it sure is. And and most of the insurance companies don't cover psych well anyway.
Nope.
So they don't. They'll reimburse if there's, they're going to make an adjustment to your medication in that visit, and that's usually about 30 minutes of a visit, or 45 minutes, not a long visit at all.
No.
They'll reimburse for that, but the kind of the therapy, that part of it, they don't really cover much. No. So the people are paying most of that out of pocket anyway. So that would be fantastic.
This is the other common complaint, or their insurance limits them to a certain amount of counseling visits with a psychologist, and then there's a huge copay with it. Psychology is another place where you could see this kind of subscription model where you purchase this, and they could even say 10 visits is going to cost you this much. Yeah, I mean, like my orthodontist, I paid a lump sum for my kids' braces, and they were popping wires and brackets were coming off. That was all included with that lump sum. That's almost like a direct care orthodontia model. So why couldn't this apply to other things?
Absolutely.
Now, some specialists
that's a really great example that a lot of people can relate to, having kids who need braces or some orthodontic, appliance, because a lot of these places, they want to know that you can pay it, and they will offer you a payment plan, or if you have like a savings account, You can pay one lump sum and you get a little bit of a discount. You pay
Mhm.
with credit card, you can get a little bit of a discount. Got more than one kid in the practice. So they've been doing this a really long time and running their practices.
A lot longer than we have. And you can use your
Yeah.
HSA for that money.
Yep.
That's
Yep.
another thing, right?
Yes, yes, you can. Yes, you
Yep.
can. And I've used that. That's the other piece of this angle that we haven't talked about on the podcast yet, but we'll be getting there
Okay.
too. But definitely having a healthcare savings account is a way to save money for your medical care. It rolls over every year and it's tax-free money. And it's your money that you're earning. If you are currently, the way it's set up, if you are employed and your insurance is sponsored by your employer, you get a high deductible health plan, and you can associate that with a bank that then takes whatever amount of money that you decide you want to spend, up to a maximum per year, plus whatever your employer, a percentage that your employer contributes. And then that money you can keep, and it rolls over from year to year, and you can use that and pay lump sum for your medical care. And if you lose that employer sponsored insurance, you still have that money saved up, but you'd have to get another employer that would sponsor you. The way it is now, you can't just go and say, hey, I want an HSA and I want to start putting my money into a healthcare savings account. And then right now, we still have the problem with direct primary care, correct? That because it's a membership fee, you're not allowed to take money from an HSA. Can you expand on that a little bit?
Well, the last administration passed a rule where you could use your HRA, which is like an HSA, but it's employer sponsored. The HSA met some resistance from IRS, and I'm on the board of DPC Action. So for 3 years, we went back and forth to DC over 20 times. We met with IRS, we met with their tax attorneys, and unfortunately, a lot of those attorneys were involved with the Affordable Care Act, and some of them actually with the drafting of it, and really couldn't understand how we're not an insurance plan. And, we went back and forth for a long time trying to explain we're not an insurance plan. We don't underwrite people's chronic conditions. Pre-existing conditions don't exist in direct primary care. We don't ask people what their chronic conditions are when they sign up. They sign up and we start taking care of them. So that doesn't preclude or cost more because somebody has 5 chronic conditions. So we're not an insurance plan, we're a subscription model. Anyway, the last administration had passed an executive order asking the IRS to clarify that HSAs, health savings accounts, could pay for a direct primary care medical service fees. And we almost got across the finish line, but not quite. We definitely have the attention of the country and the industry, because it is succeeding and patients are happy, and it's an affordable way to get good primary care. So hopefully, right now things are quiet. We're going to pick up that ball and start running with it again. So do we have patients paying with their HSAs? Yes.
Yeah.
We tell them to talk to their accountant and their lawyers about it. And, it's really their decision. We just make sure we tell them we can't advise for or against it, that they have to talk to their professionals about it.
Okay. All right. That's a bunch. Let me just make sure there are no more questions. Because I could talk about this forever with you, because I'm just so excited about this and about DPC period, and what's, seeing the growth of it across the country. It just is it's just an amazing way to get care. And it just is inspirational to see doctors like you actually being doctors and enjoying it again, and enjoying what we went to medical school for, to actually really care for people and interact with people in this intimate way, and really really help them prevent disease. And we know that primary care is key to helping people to not only prevent illness, stay out of the hospital, but also to kind of to keep them going and sustain their health, and then connect them to other specialties that they need. So
Yes.
you're really the gatekeepers of medicine,
Thank you.
and to be able to do it this way and to give people what they need in such an affordable way, and a way that just makes it so much more convenient for people. It's great. It's so exciting for me to share. This has been one episode that I've just been so ecstatic, about showing people. So everybody out there listening, spread the word, please. Let people know what this is about. Mother knows best. Yeah, she found one in her town. She used the mapper. So excited. So yay.
The center of the universe. We all know that.
Yeah. Right. So anything else you want to tell us? A good story, a success story, or something that you want to share, like maybe from this week, last week, whatever, even through the pandemic, something that just kind of gives people some hope that medicine and medical care is affordable.
I think the pandemic, I kind of hunkered down and just focused on keeping my patients out of the hospital during this pandemic, not just from COVID, but from other chronic conditions going awry, because we all saw that happen. So I really think that this pandemic showed the importance of good primary care, because COVID was not only obviously the big worry, but the care of other chronic and acute issues, they were happening regardless of COVID. And we couldn't let those get out of control. And so I think that's where the primary care part, was really important during this pandemic, and having access to me and to my time, and, talking them through their anxiety, the loss of loved ones, their kids having to go to telemedicine and all the stress induced with that, loss of jobs, working from home. That poured into the primary care office. And so DPC was wonderful that way, because I really could spend the time with the patients. One case I do want to mention, which was incredible. So, they don't let us do, in the insurance world, you can't do annual EKGs anymore. Insurance won't pay for it unless there's a diagnosis attached to it. I was trained, you do an annual EKG on everybody, just to have a baseline in case they come in with palpitations or chest pain. You can compare it. EKGs cost like $60 to run in the office for the paper. I still do them because I'm direct primary care and I'm not billing the insurance companies. I had a patient come in July for his physical, and I did an EKG on him, and I pulled up his old one to compare it. And I was like, oh, there's a change. And I said, did you have chest pain in the past week or so, or in the past few months? He goes, well, actually last weekend I did, but I just thought it was reflux. And I said, really? I said, how long did it last? He goes, a couple days. I said, what did you do for it? He goes, I popped some Tums. He goes, but I kept up my activity. I was on my roof, re-shingling my roof. And I'm like, oh. And I said, well, I'll be right back. So I called cardiology. I have a great relation. And this is the other thing we do. Specialist, I'll call the specialist right in front of the patient in the room. And I called the cardiology. I said, I'm faxing 2 EKGs over to you. Tell me if you're thinking what I'm thinking. And they're like, yes, we're thinking what you're thinking. He hadn't had an MI. He had a heart attack. He didn't even know it. So I immediately get him, and cardiology said, send him over. He went over that afternoon. This is an independent cardiology group that I work with who are awesome. And he has no insurance, the patient. And they did cash pay office visit, cash pay stress test, which was like $250. And sure enough, he had a cash pay. And sure enough, he had almost 100% occlusion of one of the,
Oh my gosh.
So the hospital worked with him and got him charity care to have a bypass done.
Man.
Right in the middle of the pandemic. Yep. So.
Wow. And if he hadn't come to see you.
For his physical, yeah.
For his physical.
And I hadn't done the EKG.
And you hadn't done the EKG, that wouldn't have been called. Now, and like I know there's still my internist works through the hospital system, so that's where I get my healthcare, and he does still do it. He's an old school doctor, and he still does it.
Yeah.
But yeah, does insurance pay for it? No,
No.
not really. And especially with somebody who's young with no risk factors, they, of course not.
It takes,
But he still does it anyway,
yeah.
and right there in his office, interprets it right there in front of me and all of that. And so, but that, I mean, that's amazing. If you hadn't done that, hadn't gotten the history, and put the two together and then had that connection, this guy could have killed over the next time he got up on his roof.
He didn't even tell me he had chest pain in the
Yeah,
history.
yeah.
Went through the whole history before, before doing the history, before I started the physical. He never told me. He just thought it was heartburn, so he didn't even mention it until I looked at the EKG, and I was like, did you have some chest pain in the past couple of weeks?
Gosh,
Yeah,
wow. I
yeah.
mean, if you had not done that EKG,
He could have
that's
died.
it. Yeah, he could have died.
Yeah.
I mean, so that's amazing. Thank you. Oh, I love that. I love that story.
That was a good one. Thanks.
Yeah. All right.
It's like my heart skips when that happens, and it's not like I pat myself on the back. I'm like, oh my God,
Yes.
What would he, I caught that. Thank God. What if I hadn't caught that? That's
all those things run through your mind, like all the what ifs.
Yeah,
but that's amazing.
Every life matters.
That is so true. I mean, oh my gosh, everybody who walks through that door, we care about them. We want them well. And we take it personally, for sure.
Yes, we do.
So bring medicine back, patient and the doctor. Yep. It's like we always say here on Free to Care, the podcast, medicine is personal. It is not partisan. These are solutions that cross the political lines. This is not something that Democrats fight for and Republicans don't, or vice versa. But it is a way to get back your healthcare choices and your healthcare freedom, and for doctors to have their freedom to practice again. So, Dr. Corba, thank you so much, Kim, for coming on.
Thanks for having me
and blessing me with your presence. I love it. I know you just get to go connect with your family and the dogs and the cats and everything.
You can probably hear them barking in the background. We're very upset
your busy day.
Yes. And Nikki, I haven't seen you in a while since we were in DC, like 2.5, 3 years ago. So you look great. I'm glad you're well. I'm glad you're well. And thank you for having me on.
You too. Good night.
You too. Kisses and hugs.
Okay.
Bye. Thank you.
Bye.
Bye-bye.
All right, guys, just closing up a little bit. Thank you so much for tuning in. This is one of my favorite episodes so far. And the more of this is to come. All of the ways that we can talk about to get you lower cost healthcare. Next week, we will be doing, I believe it's next week. I'm losing my mind, but I think it is. Yeah. On the 18th, Friday at 8 p.m., we're going to be talking about the pharmacy benefit managers and how to get lower cost of your medications, your supplies. We're going to be like really reining in on the big health cartel. So we want, I want you guys all to join me, share this podcast, share it from YouTube, share it from Libre TV. .co. Just spread the word, spread all the information out there. Go find yourself a direct primary care doctor or surgeon or specialist in your local city using that dpcmapper.com that's there. Also, check out Saul G tomorrow on LibreTV.co. He is going to be doing his Kamikaze show about hopefully we're going to be talking about the new Loki show tomorrow at 7 p.m. And Corey, we're not sure if we're going to get a live corrected felon or not, but God bless you and safe travels, and you and your wife dealing with your tragedies there. But yeah, I'll be back next week on all the LibreTV.co family. Wishes you a good night and a wonderful weekend. And check us out, freetocare.org.